Good afternoon, folks. Welcome to the annual Whyte-Schwartz Lecture. It's a pleasure to see you all here, and I know we have people online as well. I think that's all okay. If you could just check, Anthony, if they can hear me. So this is an annual event, but we have monthly lectures as well, but it's a special occasion because it's in recognition of the founders of the Institute more than 30 years ago, Dr. Whyte and Myrna Schwartz, director and associate director respectively, and specifically the theme, the translational nature of our research spanning behavioral cognitive behavioral change and theoretical aspects right through to the clinically applied. And so it's very fitting our presenter today. So just to recognize Dr. Whyte and Dr. Schwartz, and thank you for coming along as well. So it gives me great pleasure to introduce Professor Jennie Ponsford, who is one of the leaders, if not a leader in the world in traumatic brain injury research. You'll notice she probably has a stronger Australian accent than I do. But is no doubt influential right across the world and has, a string of awards, a very impressive CV, some 35,000 citations, an H-index approaching 100, publishing it in really esteemed journals such as New England Journal of Medicine, JAMA, and has made a tremendous contribution to the field of traumatic brain injury, and in particular, has overcome challenges and still is faced with challenges about how to translate knowledge from randomized controlled trials into clinical practice and influence clinical practice. And it's hard work, and you've done so well at doing that, and I know you're continuing to do that as we move forward. So Professor Jennie Ponsford is the Sir John Monash Distinguished Professor of Neuropsychology in the School of Psychological Sciences at Monash University, Director of the Monash Epworth Rehabilitation Research Centre at Epworth Healthcare in Melbourne, Australia, and I mentioned has received a number of awards, but one of them is Officer of the Order of Australia, which is a very distinguished award in Australia for contribution to humanity in general. Her talk today is Improving Outcome After TBI with Evidence-Based Rehabilitation. Welcome. Thank you.
Thank you, Dylan, and I'm enormously honoured to be invited here. And I have told others that I first came here in 1987 because I had very much admired the work of Nate Mayer and the work that was happening in slow to recover patients with traumatic brain injury in those days. And then over many, many years have greatly admired John Whyte and Tessa Hart and all of the work that they've been contributing in this space. And the thing that most characterizes the work of Moss is the incredible adherence to good science, and probably much better than I've managed to achieve. But it's certainly, I'm a great admirer. So thank you very much for inviting me here today. So I need to show you these CME slides that talk about conflicts and so on. What I'm hoping by the end of this talk is that you will have an awareness of the long-term issues people with traumatic brain injury face, which I'm sure many of you already know, have knowledge of ways that one might address some of the key challenges, and also then know something about how to implement treatments into clinical practice. So much of what I had done has been carried out at Epworth Healthcare in Melbourne, formerly Bethesda Hospital, where in 1982 I was part of the team that set up a traumatic brain injury rehabilitation program under the auspices of our no-fault accident compensation system that we have in our state and which continues to the present day. So very early on in the piece, we realised that we needed to be following up our patients to find out how they went. And so in the late 1980s, we set up this prospective study that's been kind of a mini model systems and actually has operated pretty much in parallel with model systems to the current date. So we've got about 3,500 patients and we're out to 30 years follow-up, documenting their functional, cognitive, psychological and social outcomes, the factors associated with those outcomes, injury-related factors, personal factors, social and psychological factors. And all of this, of course, though, is used to inform the design of interventions to improve outcomes. Our patients have predominantly moderate, severe or very severe head injuries. So what I'm saying today will not apply so much to people with mild head injury. So when we follow them up, we compare them with healthy controls who are marked in white on these graphs. And as you can see, they make very good recoveries in terms of independence in activities of daily living. About a quarter need some supervision in shopping, banking and financial management. Many get back to driving and the use of public transport. But despite this, only about half are able to return to their previous leisure activities, and only about half of those employed prior to injury are able to return to employment. We also see high levels of social isolation. At 1 year, about a third tell us that they've lost friends or become more socially isolated. And by 10 years, though, it's closer to half of the cohort. We also ask about sexuality, and although there are the small subgroup of about 16% who report increased sex drive and disinhibition after traumatic brain injury, the vast majority report a significant decline in their sexuality and relationship quality. So what are the factors then that contribute to these reduced levels of participation after traumatic brain injury? Well, of the neurological complaints, fatigue is by far the most common problem, reported by over 60% of these individuals, followed by problems with balance and a range of sensory disturbances. We do see very good outcomes generally in terms of mobility, with only about 10% needing aids to mobilise. In contrast, the vast majority of these individuals are self-reporting very significant cognitive and communication difficulties, 80% reporting problems with memory still persisting at 10 years post-injury, problems with concentration, slow thinking, cognitive fatigue, word-finding difficulties, difficulty following conversation. And there's a growing awareness of these difficulties as evidenced by the increased self-reporting of difficulty planning and organising things over time. We also see behavioural changes with more than half, up to 60% reporting increased irritability or short-temperedness, but also in people telling us that they need more prompting to get things done, are more self-centred, more impulsive, and more likely to show inappropriate social behaviour. And not surprisingly, given all these disabilities, we're also seeing high levels of emotional distress, with about half reporting clinically significant levels of anxiety and or depression. So based on these outcome data, I have identified just a few of what I see as the major impediments to better outcomes following traumatic brain injury. So these include the presence of memory and attentional difficulties, fatigue, and I would add sleep disturbance, irritability and anger management, anxiety and depression, and changes in sexuality. You will forgive me, as a neuropsychologist, I am much more focused on psychological and social issues than physical issues. I know a lot of you do absolutely wonderful work in addressing physical problems after TBI, but I am going to focus on the psychosocial impediments. So what I'm going to do now is talk to you about our efforts to address these problems. The Myrna Schwartz Rehabilitation Research Centre attempts, in its work, documents the outcomes, the difficulties people experience in the acute and long-term stages after traumatic brain injury, concussion, and stroke. But as you can see from the third column, we're also very focused on developing treatments to address those problems. and now increasingly focused on translating Goni into clinical practice. Over the last few years, I've been involved with a group of people from Canada, US and Australia in developing and then updating the INCOG guidelines for cognitive rehabilitation after traumatic brain injury. I'm not going to talk in detail about these guidelines, but I will address the memory topic. So Conja led this guideline, which states that training in internal compensatory strategies such as visual imagery or self-talk strategies may be effective with people with mild to moderate memory difficulties. They need to have some level of self-awareness to know when and how to use those strategies, but they can benefit from training either in group or individual contexts. Those with more severe traumatic memory difficulties are more likely to benefit from environmental supports or reminders. But those people need careful consideration as to the suitability of aids. They need to be selected based on their previous use of these strategies, their cognitive strengths and weaknesses, and their physical comorbidities, as well as the portability and cost of these aids. Now, much of the work that we've actually done in this space has, I have to admit, been done in the area of stroke. One of my doctoral students, Tony Whittile, worked with Ilana Roll and Renee Stolwick to compare outcomes following restorative and compensatory approaches to memory rehabilitation after stroke. So the restorative side of it was delivered using Lumosity. We had people use Lumosity, which is a program designed to train people to remember patterns and locations, ACE name associations, working memory, and so forth. And they did this for 30 minutes, 3 to 5 times a week over a 6-week period if they were randomised to this condition. Those randomised to receive the compensatory strategy training received this in a group context. They attended once a week for 2 hours over a 6-week period. And we followed this Making the Most of Your Memory program that had been developed by Kylie Radford, providing education about the stages of memory, training in internal strategies such as learning face name associations, use of external memory aids of various kinds. And they also worked on optimizing the home environment, getting adequate exercise, nutrition, minimizing mood and stress issues, and maximizing sleep. So what we and the participants in this study were randomized to one of 3 groups, the restorative, compensatory, or a waitlist control group, and they set individualized goals. For example, to improve my memory for names, using goal attainment scaling. And so we assessed the attainment of goals at the end of the intervention and a follow-up, and found that those who had received the compensatory memory strategy training were showing better goal attainment at the end of training and at follow-up. But there were no significant changes in performance on formal memory tests. Perhaps more importantly, when we asked the people how they found the training, those who'd attended the memory strategy group said they had acquired useful tips that they were able to use in their everyday lives, whereas those who'd done the Lumosity training said that they found the exercises didn't translate that well to their everyday life and felt their memory was just as bad as it had been. Of course, not everyone can attend a memory group in person. And so we felt it was important to evaluate delivery of this intervention via telehealth. So we had another doctoral student, David Lawson, conduct a trial on individual delivery of the compensatory strategy training as compared with in-person delivery, as compared with the group delivery, and found no significant differences in the benefits. If anything, those receiving the telehealth health delivery benefited more because they were very highly motivated. So this intervention, which we had actually subsequently trialled on people with traumatic brain injury, but in the stroke realm, Dana Guang has done a lot of work with translating this into clinical practice. So it was formally trialled with cost-benefit evaluated in a couple of hospitals, and it's now being delivered in more than 15 health services across Australia. And the telehealth version has been provided to more than 100 clinicians across 6 countries. I'm going to move on now to talk about quite extensive work that we've done in fatigue and sleep disturbance. So I first started studying this in 2000, and this work continues till today. But we find that fatigue and sleep disturbance are reported by more than 60% of people with traumatic brain injury. And our studies looking at various associated factors have identified that they're definitely associated with each other, but also that they're associated with damage to sleep, wake, and arousal centres, but also with impairments of attention and speed of information processing. Both problems are also, however, very strongly associated with depression, anxiety, and pain. So my colleague Michael Schoenberger constructed this structural equation model based on a prospective study of about 144 people with traumatic brain injury whose fatigue was monitored over a 12-month period, and found that factors such as the presence of daytime sleepiness and poorer vigilance performance were associated with fatigue, which in turn led to the development of depression and anxiety that in turn then fed back exacerbating daytime sleepiness. So there was a somewhat circular association, and we felt that we needed to be addressing all of these factors in order to alleviate fatigue. We were also interested in the impacts of traumatic brain injury on circadian rhythms, and to that end monitored melatonin levels. So melatonin is a naturally occurring hormone secreted by the pineal gland. The levels rise in the evening, and it's associated with the onset of sleep. So we found in traumatic brain injury patients relative to age-matched healthy controls that they were producing significantly less melatonin throughout the night, and that these lower levels of melatonin were associated with less rapid eye movement sleep. So this led us to think that we may alleviate sleep disturbance if we administer exogenous melatonin. And this was the focus of a trial by one of my doctoral students, Natalie Grimmer. I do have some very good chronobiology colleagues at Monash who had facilitated this work as well. So this was a 10-week randomised double-blind placebo-controlled crossover trial. So they had 4 weeks of melatonin, 4 weeks of placebo in a randomised order. And they were community-dwelling people self-reporting changes in sleep following TBI. They were not allowed to be taking other forms of sleep medication. So the active treatment was Circadin, and a synthetic form of melatonin in a 2 milligram dose. And this was used because it's been shown to alleviate insomnia in older adults. And we had an identical placebo. So what we found, it was in the end quite a small trial because melatonin is so widely used anyway that it was difficult to get people to agree to the trial. But we did find that during the melatonin phase, participants did report significantly improved sleep quality on the Pittsburgh Sleep Quality Index, improved sleep efficiency on actigraphy, lower levels of fatigue and anxiety symptoms, and improved vitality and mental health. And importantly, melatonin was well tolerated and associated with no serious adverse effects. So melatonin is now very widely used as a relatively harmless treatment for sleep disturbance following traumatic brain injury. Another approach that we have taken is light therapy. And again, this is thanks to my chronobiology colleagues at Monash. So light exerts a number of non-visual effects on various biological functions. It can reduce sleepiness, increase body temperature, heart rate, melatonin levels, sleep architecture, vigilance performance, and it can improve mood. And it's light in the short wavelength or blue range that is most effective in this respect. So this led us to conduct a pilot trial where we had people who were self-reporting problems with fatigue and sleep disturbance sit in front of a blue light box for 45 minutes within 2 hours of waking in the morning. And their levels of fatigue and sleepiness were compared with a group who were exposed to a placebo yellow light box or a treatment as usual control group. And we found that those who were exposed to the blue light in the mornings did report significantly lower levels of fatigue and daytime sleepiness. There was a trend towards lower levels of depression. There were non-significant improvements in reaction time and no significant changes in sleep quality. But of course, when they were no longer exposed to the light box, their levels went back to baseline. So it's quite onerous to sit in front of a light box for 45 minutes in the morning. So this led us to consider whether it might be possible to change lighting letters in the home where people were spending most time to expose them to the right kinds of light. So this was the work of another doctoral student, Laura Connolly, who went into people's homes with a light meter, assessed the lighting in different parts of the house where they spent time at different parts of the day, and had a prescription with an electrician who changed the light bulbs to have high intensity blue enriched or high melanopic light in areas where they spent time during the day as a stimulant, and then dim and blue depleted or low melanopic light gradually before sleep as a soporific. So the light bulbs, which were just bought from a hardware, were integrated into the ceiling. If there were 2 circuits, they would have a daytime circuit and a nighttime circuit and would just flick a switch 3 hours before bedtime. This was supplemented by programmable or simple lamps placed in strategic areas. And the placebo was a sham condition that approximated their usual lighting condition, such that they did not know what lighting they were being exposed to. So we conducted a randomized controlled trial, which we've got to 49 thus far. It was very disrupted by COVID because we couldn't go to people's homes for 2 years in Australia. So there was a baseline 2 months of one condition, either active or placebo, to which they were randomized. Then they crossed over to the other condition, and then there was a 4-week follow-up. And we assessed outcome on in terms of fatigue, sleep disturbance, reaction time, activity levels, depression, and participation. And so we have, as I say, managed to study 49 people to date. They had an average PTA of those with, we have mostly TBI people, but we do have 8 stroke people in this sample as well. And they're an average of 12 years post-injury. And what we've actually found, these are quite new data based on these 49 people, is that there is during the active treatment phase, a significant decrease in fatigue, a significant decrease in sleep disturbance on the Pittsburgh Sleep Quality Index, and a significant increase in productive daily activity. There's a decrease that arrows in the wrong direction in their sleep onset latency, and a significant decrease in their sleep disturbances. No significant effects in other variables as yet. So this slide just shows you that was the treatment effects, or the active treatment is on the left and the placebo is on the right. And you can see that most of the measures are showing effects in the desired direction that revert back towards placebo during the placebo phase, back towards baseline. So we're quite excited by this because it really doesn't demand very much of the patient. They only have to flick a switch 3 hours before bedtime. It's been interesting to get effects on sleep as well as fatigue, which we didn't get in the earlier trial. And that seems to be very much associated with that exposure to the low melanopic light in the evenings, which was added in this condition. And so it does show promise. It's fiddly, you have to know about light, but it does show promise as a treatment for fatigue. So the third approach that we have taken to addressing fatigue and sleep disturbance is a psychological approach, because we know that there are many psychological factors involved in fatigue and sleep disturbance. And this is work that's been led by another two of my doctoral students. So the first of them, Sylvia Nguyen, developed an adapted form of cognitive behaviour therapy to address both sleep and fatigue. We thought it was important to address both these problems because they co-occur in about 75% of cases. So this involves 7 modules, and the treatment is adapted to accommodate cognitive impairments. So just to outline the intervention, it involves provision of psychoeducation to normalise the experience of sleep and fatigue, setting individualised goals with a focus on more sleep or more on fatigue, depending on the individual, setting up a treatment plan and getting them to keep sleep and activity diaries. We then would examine those diaries and set individual goals depending on that person, and set up pacing to either increase activity or decrease activity, with the goal of interspersing demanding physical and mental activity with periods of rest throughout the day so that their body battery doesn't run down completely. We also provide education about having regular sleep-wake times and adhering to sleep hygiene principles. And so there's a graduated, there's a review of the activity program at every session, and the activity levels are gradually increased or decreased according to the goals of the therapy. And obviously you're needing to work on the person's cognitions around their activities, which inevitably need to be modified. We also have specific sleep interventions. So stimulus control involves focusing on maximising the use of time in bed for sleep, not other activities such as watching television or reading, minimising time spent tossing and turning in bed, going to another room and doing a relaxing activity. If you're lying awake, learning relaxation techniques. And we also might restrict the time spent in bed to maximise the time spent asleep. In terms of, there's also specific strategies for physical and mental fatigue. So, for example, time pressure management to teach the person strategies, for example, to tape record a meeting to minimise the stress on their slow processing speed. And then the final session is a review of the techniques and discussing ways to prevent relapse. So Sylvia trialled this in 36 people with stroke and traumatic brain injury, as compared with a no treatment as usual control group, and found a significant reduction in sleep disturbance, fatigue and depression symptoms that was maintained or consolidated at 2-month follow-up. But of course, we didn't know whether that treatment was having an effect because the person spent 8 weeks with a therapist focusing on sleep and fatigue, or whether it was the actual content of the CBT. So we then commenced another randomised control trial led by Lucy Weimer that involved an comparison with an active control intervention that was a health education control intervention that involved spending 8 sessions with the therapist and receiving information and handouts on brain injury, sleep, fatigue, diet, exercise, stress, substance use, and cognitive difficulties. But importantly, there were no specific strategies applied for that individual and no homework strategies. So for all Tessa Hart's model, we actually randomized people 2-to-1 to receive the CBT as opposed to the health education. We had both stroke and TBI people in this trial. 42% of them had TBI. They were of similar age, gender and education. Those with PTA had 2 to 3 weeks of PTA, and those with stroke had predominantly ischemic stroke. Now, this intervention ended up being delivered during COVID, and so a lot of people had to receive it via telehealth. So we also looked at whether receiving the intervention in person or via telehealth made a difference. So what we found was that during the period of the intervention, which is the first phase you see, there was a significantly greater reduction in sleep quality on the Fitchburg Sleep Quality Index, and that was largely maintained. But over a longer period of time, the health education group did show improvement, such that at 4 months there was no significant difference. On the fatigue severity scale, they also showed a greater reduction in fatigue that was maintained at follow-up, but there was also some improvement in the health education control group. We saw similar gains between stroke and TBI participants, and there were no differences between in-person and telehealth delivery. In terms of anxiety and depression symptoms, we again saw greater reduction in depression during the intervention, but the health education group actually overtook them, and there were, again, no differences at follow-up. So overall, our results suggest that the CBT does confer faster and quite lasting benefits, but clearly that health education is also having some benefit. We feel it may have resulted in changes in lifestyle that led to much more gradual improvements. Again, no differences between stroke and telehealth. And the better outcomes were in those who had greater symptom severity at baseline and higher education. So we have completed a qualitative study interviewing 20 of the participants who received the active intervention about their experience. Actually, we did interviews with both types of intervention. But what they told us was that they came into therapy very desperate for help, and they felt it was very important that they had accepted that they couldn't cure their sleep and fatigue, that they needed to take control of their symptoms and put in hard work to overcome them, and that hard work needed to continue for the results to continue. We've also done a cost-benefit analysis of this intervention, comparing the health education and the CBT, and found that the CBT was more beneficial in reducing health service utilisation and reducing overall health system costs, and in terms of the improvements to quality of life at 2 months. So it was concluded that it was most likely cost effective. Of course, this isn't a comparison with CBT with no treatment at all. So we have now manualised this intervention, and it is in press with ASB resources, and we're now in the process. Last year we ran a workshop for 75 clinicians, and we are in the process of analysing the outcomes of that in terms of finding out, the clinicians told us they benefited on the day, but we're now trying to follow them up to find out how much they've actually used the intervention. So now I'm going to move on to talking about challenging behaviour, which really represents one of the most significant challenges that are faced by people with brain injury in integrating into the community, by their close others, and by the clinicians who treat them. Despite that, we find that the vast majority don't receive active support in managing behavioural issues, and that clinicians, when we've surveyed them, really struggle and muddle in addressing these issues. So we were very fortunate to get to work with Tim Feeney and the late Mark Ulgasaka, who are really being masters in adapting positive behaviour support interventions to address challenging behaviour. Working with Tim Feeney specifically, we refined their positive behaviour support approach, and have called our approach PBS Plus. So this is a multi-component approach that combines PBS practices, the usual PBS practices, with cognitive executive, communication, and psychological strategies that are specific for people with brain injury. So the plus in PBS Plus is an acronym for the principles of person-driven learning together, uniting supports, and skill building. So PBS Plus involves, from the outset, setting collaborative goals with the person with a brain injury about what would make their life more meaningful, and also involving their natural supports, their close others. And then setting about addressing the barriers to achieving those goals that invariably include addressing challenging behaviours, but also other challenges. And we do that through skill building, restructuring the environment, and teaching executive strategies such as cognitive communication scripts. There's very strong collaboration with the natural supports in their lives, because the aim is that they would take over and continue on this intervention after the therapist is no longer involved. It is a transdisciplinary intervention, so it has been delivered by neuroscience, OTs, and speech pathologists. So we were fortunate to be funded by the Transport Accident Commission to conduct a single-blind waitlist controlled trial evaluating this intervention, because the participants had quite severe challenging behaviours, and they had to show those on the overt behaviour scale. It was a 12-month intervention, with those randomised to the waitlist control group having been free to seek whatever treatment they liked, and then they got the treatment after 12 months, and then there was a 12-month period of follow-up. So we had 49 in the trial. I mean, there even included people who were non-verbal in nursing homes, very wide range. Only 10% were in employment. They had predominantly TBI, stroke, and hypoxic brain injury. And the predominant behaviours were verbal aggression, inappropriate social behaviour, and lack of initiation. So when you do these trials, you have to take the good with the bad. So what we found, this is the results on the top left are the results for challenging behaviour on the overt behaviour scale over the first 12 months of intervention. The blue line represents the active treatment group, and the red line is the waitlist control group. So the active treatment group did show a significant reduction in challenging behaviours on the overt behaviour scale, but so did the waitlist control group. It transpired that they had been accessing a lot of help, psychological and behavioural help. They had up to 26 sessions, the waitlist control group, an average of 6 sessions of help over that year. But when we combined the groups, which is in the bottom left-hand slide, you can see that overall the groups showed significant improvement, and then at the end of 12 months, their gains were consolidated over a further 8-month period with no engagement with the therapist. They reverted a bit back towards baseline, but still remained below baseline at 12-month follow-up. Our secondary outcome was the extent to which the close others had increased their confidence in managing the challenging behaviours, and there was a statistically significant improvement in that was not evident in the waitlist control group, and that was maintained over a 12-month period, which attests to the engagement with the close others in the intervention. We found that 84% of the individualised goals set were achieved, 53% were exceeded, and a qualitative interview with 52 of the brain-injured participants and close others, 90% did report favourable perspectives on the intervention. And when we interviewed the clinicians, they said that delivering this intervention had allowed them to have more humanity as a clinician, to work much more than they usually would alongside the person with brain injury and their close others, and that they felt that the response was so much greater because they were working almost as colleagues rather than overly. So Kate Gould was the clinician who led this intervention, and she has now gone into active translation phase. She has created an interactive online learning hub because we really believe this approach to managing challenging behaviours is effective and helpful. It's got recorded lectures and workshops and a number of intervention resources. So she has co-designed with people with brain injury and close others an intervention guidebook that is currently in press with ASB resources. She has created a clinic at Monash University where we train our doctoral students to deliver this intervention, and was funded 3 years ago to conduct whole service training for the clinicians working in the public sector in South Australia. So that involved running workshops and conducting intensive supervision for a subset of clinicians, and they now have an ongoing community of practice. And she's now being funded to train up the private sector in that state. So anxiety, I'm going to move on now to anxiety and depression. We know these are very significant problems. I've just been talking to Amanda, who's doing active work in this space. This was one of the earlier intervention studies that we conducted where we developed an adapted form of cognitive behaviour therapy to address both anxiety and depression, since they coexist in many cases, and importantly adapted this therapy for cognitive impairments, incorporating concrete behavioural goals, handouts, repetition, use of memory aids, and we built booster sessions into this. And we used a very concrete cognitive therapy concept. So these are the components of the intervention involving anxiety management, behavioural activation, thinking strategies, graded exposure, structured problem solving, self-soothing strategies, and relapse prevention. And we conducted a randomised controlled trial comparing outcomes 6 months following enrolment in 75 people who were self-reporting significant anxiety and depression symptoms, and found a significantly greater reduction in both anxiety and depression symptoms and an increase in psychosocial reintegration in the treated group relative to a treatment as usual control group. And this intervention has been published by ASB resources in this manual. So we then set about translating that intervention into clinical practice, and these efforts were led by Dana Wong. The first step was we ran a workshop for 75 clinicians that not only told them all about the intervention and the research we've done, but included a lot of practical application of how to adapt CBT for brain injury, videos of therapy and role plays. And participants were given the option of 3 sessions of clinical supervision after the workshop. So we evaluated the workshop with case vignettes before and after, and competency checklists. And then those who undertook the further supervision had an independent therapist rate their tapes of work with clients on the cognitive therapy rating scale. We found that the participants in the workshop did report significant gains in their skills. They said that the most helpful components were the practical components, showing the adapted CBT in action, that most improved their skills and confidence. Actually, the self-report from the people that underwent the further supervision didn't report further increases, but it was the case that the ratings by the independent therapists on the cognitive therapy rating scale did show an increase in their skills following the 3 sessions of individual supervision. And when Dana conducted a survey 16 months later, She asked the participants in this study what were the most frequently reported barriers. So before the training, they said it was that they weren't confident enough and they weren't feeling adequately trained. But at 16 months later, it was that they didn't have enough time or it wasn't part of their role. And therein lies one of the major impediments to implementation of clinical interventions, very sadly. Now, finally, I'm going to talk about how we have addressed sexuality. For years, I have been documenting the negative impacts on sexuality through our longitudinal outcome study, but really haven't done very much about it. And then I have had 2 doctoral students come into my life who have been willing to address this somewhat sensitive topic. So Eleanor Fraser set about designing a cognitive behavioural intervention to address satisfaction with sexuality. So this is an 8-session cognitive behavioural intervention. It is based on very individualised assessment and formulation because the presentations are very many and varied. And so they undertake collaborative goal setting and then select from 12 modules based on the client's individual formulation. There's also the option of medical review. For example, if the person has erectile issues or there's potential impact of medications on their sexual function. But the therapy is delivered following a CBT framework. So the treatment is offered either in person or online. Again, a lot of this research has been conducted through COVID, but interestingly, almost all of the participants have opted to do it online. They're also offered it as either a couple or individually. And it's been interesting that only 3 people, lots of participants have undertaken it as a couple. So these are the 12 modules. Some of these modules are delivered routinely. So obviously psychoeducation and the maximising gains. But the other modules include self-esteem and body image, understanding arousal, communication, relaxation, psychosexual skill exercises, social skills, and sleep and fatigue. And Eleanor developed these fantastic resources, handouts that go with them. And so the therapy is delivered by 2 clinical psychologists. So we have had 16 people complete this intervention. I'm still trying to get funded as a randomised controlled trial. If you think it's difficult to get funding for any of your topics, try to mention the S word and there is just no way. Anyway, I have been funding it from my money. And so we're actually up to 22 people in the trial, but these are the results for 16 of these people. 10 were partnered and 6 were single, but as I said, only 3 undertook it as couples. They range from 10 months to 33 years post-injury and had an average PTA of 4 weeks. So as I said, there are 16 people. We conduct it as a single case design, a series of single case studies, with the dependent variable being their satisfaction with their sexuality, which is self-rated 3 times a week throughout the baseline, intervention and follow-up phases. And there is a booster session offered at the end of the follow-up phase. Now, these are the ratings of sexuality that you can see on the screen. 75% of the participants have shown statistically significant gains using Tau U statistic, either during the intervention or at follow-up. And even although there are 25% who haven't reported statistically significant gains, every one of the participants has achieved at least one of their individualised goals. And we've also seen gains on the other measures of things like the sexuality on the BIQS, anxiety and depression, self-esteem, and so forth. But just to give you a handful of case examples to illustrate the range, there's two 60-something-year-old men who had erectile issues. The first was 6 years post-injury, married, and he hadn't had sex with his wife for 6 years. So he, through doing psychosexual exercises, was actually able to achieve an erection and an orgasm. And then towards the end of the therapy, the focus was on trying to reestablish his sexual relationship with his wife. The other man had had severe pelvic trauma. There was no return of sexual function. And in his case, it was more about addressing his attitudes towards his masculinity and working on ways in which he could have a satisfying physical relationship with his wife in other ways. Then there was a 56-year-old female, single, who had developed an intolerance to touch, and her homework exercises were to have remedial massage. She gradually increased her tolerance to touch, and then they started working on a plan for dating. And the final woman was undertook the therapy as a couple. She was a 41-year-old female, 10 months post-injury, who had been struggling with their intimacy. She had significant behavioural problems and fatigue. And the focus of the therapy was on facilitating their communication and then undertaking psychosexual skill exercises, but very much taking the emphasis off the sexual act, at least initially. So finally, we've been very acutely aware that clinicians do not raise the topic of sexuality with their patients, and this became evident in a national survey that we did, and was also evident at Epworth, even though they'd had previous interventions with resources given to them. So another of my doctoral students, Jill Long, has worked with me to facilitate greater talking about sex at Epworth. And we did this by running focus groups. We had 26 clinicians attend these focus groups with multiple disciplines. First, to brainstorm ways what were the main barriers to talking about sex with patients, and then looking at our analysis of those data indicated that they lacked confidence in the potential for initiating change and whether any change would be sustainable. There was also clear that there was a lot of discomfort and uncertainty about how to address sexuality, that they just didn't have the training or the resources, but also that it was not a priority in the acute stages of recovery after brain injury. So we then had identified some solutions, needing to develop resources, roles and referrals, training, have a conversation, how to have a conversation, and make changes to the case conference format. And they, in the second focus group, they were in pairs addressing this. I'm nearly done. And then Jill went away and developed these resources, a handout for the patients, about sexuality, and it was discussed how that would routinely be given out by the social workers. And there was an infographic for the staff with directions as to what they should do if a patient raised sexual issues. We had a training workshop, discuss scenarios in which this topic might come up for each discipline, and then role played how to have that conversation. We changed the case conference format so that it was routinely raised in case conference as a topic, and the neuropsychologists fortunately agreed to be the key people to routinely raise this topic with their patients, and it was also incorporated into the discharge protocols. So Jill looked at some patients before and after this intervention to look at their frequency with which they were offered sexuality support, and did find a significant increase in that frequency following the intervention, from 16% to 54%. and the patients were more likely to seek professional help should sexuality issues arise, although there was no change in the frequency with which they were self-reporting changes in their sexuality. From the clinician's point of view, from interviews and surveys, we saw improvements in their attitudes and beliefs regarding sexuality support. There was an improvement in their attitudes, a lot more normalisation of the topic. It was more on the team's radar, but it was clear that there was still lingering discomfort around the topic and that they were still quite reliant on the champions to be the ones to raise the topic. So that brings me to the end. For all of these interventions, and there are others that I haven't had time to talk about today, we are creating resource books, providing training and supervision for clinicians, both face-to-face and online, and all of the interventions are being validated for delivery via telehealth. Clearly, though, there are many hurdles still to be overcome to achieve translation of these interventions into clinical practice. But I hope I have shown you that we are progressing towards creating an evidence base and resources with which to address the cognitive, behavioural and emotional problems after traumatic brain injury. But always remember that meaningful outcomes require a focus on the individual. In closing, I do need to just acknowledge the amazing team that worked with me at the Monash Epworth Rehabilitation Research Centre. The Transport Accident Commission has funded our longitudinal outcome study and some of those trials since 1995 continuously, and the NHMRC, which has supported me. Thank you very much indeed.